the disease with 1,000 faces. Difficult to diagnose, complex, and chronic. It will strike 1 in 900 Canadians. Lupus. This autoimmune disease alters patients' lives, and if left untreated, can be fatal. At the BC Lupus Society, we provide support to people living with lupus. Because lupus is unpredictable, we strive to be dependable. Our programs include weekly support groups for patients and families in British Columbia. We make sure that educational resources and peer contacts are always available, including for patients facing a new lupus diagnosis. And every year, we help fund clinical training and medical research that benefit people with lupus. Through the BC Lupus Research Scholar Program, our goal is to advance treatments and discoveries to change the future of lupus. Our partnership with university researchers is unique in Canada and has helped understand the full impact of lupus and the effectiveness of lupus care. As part of our community, you're a valued part of annual events like our Lupus Gala and the Shed Light on Lupus Walk. These fundraising activities generate just part of the funds needed to sustain our work in patient support and medical research. With the generous support of donors like you, the BC Lupus Society will continue to be here for patients and families affected by lupus. Not only can we change tomorrow, we can brighten today. Thank you from the BC Lupus Society.
Hi there, I'm Dr. Judy LePage, and I'm going to be talking to you today about the psychological impact of lupus, approaches for managing your emotional health, and some of the recent treatment trends. So let's get started. So managing pain and fatigue involves far more than medication, as we know, and understanding how our brain processes pain and what we do with that information is where we're going to start. So the brain and pain. Normally pain is an alarm system, and our body responds when there's either tissue damage about to occur or has occurred. And so it's constantly bombarded by signals, and it has to decide what to respond to and what to ignore. And so we tend to respond to signals that are danger, and we tend to try to ignore things that are not danger. So if a smoke alarm goes off and it's just the toaster and we know that, we might ignore that. But if a smoke alarm goes off and we don't know that just, someone has burnt the toast and the house is on fire, we aren't going to ignore that danger signal. So when pain is ignored, the system may speak louder to get your attention. But is it the house on fire or is it toast? Just burning in the toaster. So our alarm system can become oversensitized at times, and there are techniques that can calm it down. So how we respond to pain and illness might not always reflect what's actually happening in the body. A paper cut, perhaps, for example, can actually hurt a lot, although there's very little damage. Pain can be delayed after a fall or a motor vehicle accident. There may be times where you have fallen and you seemed okay when you got up, but a few hours later you felt very stiff. Or if anyone's been in a motor vehicle accident, they might feel pain immediately, and it might not set in until the following day. And that's often soft tissue pain. So pain and fatigue can sometimes be deferred when we decide that something is necessary. For example, we feel we have to put on a family dinner, we have to walk the dog, or we have to perform some sort of gardening task. Somehow we fight our way through that, and then eventually we feel the pain and fatigue afterwards. And so we have either a flare-up or we pay for it for a day or two or even longer. So again, illness and our perceptions of that are also very tied together. So pain and illness is not really all about the tissue damage or the amount of tissue damage that you have or the degree of pathology, inflammation, etc., that is seen on x-rays or blood work. But it is more about the way that each person experiences their pain, their perceptions about pain and illness, and their previous pain experiences, if they've had any, family background, what did we observe our parents doing, or our brothers and sisters or aunts and uncles doing when they were struggling with an illness or pain. Our personality will have a lot to do with how we deal with pain and illness. Gender does play a role, religion and cultural values. All of those factors can play a role in how we experience pain and illness. Also, our beliefs, our emotions, and our behaviors are very tied to all of those things, and can also play a very significant role in what we do and how we deal with a diagnosis like lupus. Also, our illness our identity can be tied to illness or injuries. So, what have your symptoms changed? Have they changed the way that you do activities? Possibly, probably. The type of activities that you do, how you view yourself, how others view you, or how you think others view you. So if you were someone that was very active into sports or into a particular type of professional activity, and you're no longer able to do that, or you have to modify how you do that, then that can really impact how you feel about yourself and how you think others see you. They may or may not see you the way you think, but basically, it's really more about how you perceive it rather than what's actually happening sometimes. But it is actually good to check if you are able to find out what other people are thinking rather than what you think they're thinking. So have you basically defined your lupus, or has it defined you? And how can you redefine yourself so that you're not being defined by your lupus? So beliefs and catastrophizing. So beliefs can influence the perceptions that we have about pain. It actually predicts pain and disability and the chronicity of a disease more than the actual tissue damage or severity of a condition. And reductions in catastrophizing, or how we see the worst in a situation, can actually decrease pain and disability. And catastrophizing is defined as rumination. So we think a lot about a situation. We're spending the majority of our time thinking about a situation. We're feeling helpless and hopeless, and we're magnifying basically the pain-related symptoms so that we are often thinking of the worst case scenario. So that's what catastrophizing is, and that's sort of an extreme example of what we can be doing that will actually make our situation worse, and it will affect our behavior and, of course, our emotions as well. And it's very difficult when you have a condition like lupus, where much of the time, many of the symptoms can be invisible. You can feel invalidated by the medical process, by your family, by your friends, by your coworkers, because you might be experiencing extreme fatigue, inflammatory symptoms, and those things can't always be seen by others, and you look okay. So if you don't look sick, then why can't you do certain activities? And so that's often what people with invisible conditions, or mostly invisible conditions, face a lot of the time. It's a challenge to get the support that you need at times, and being able to communicate your symptoms can also be problematic, because again, people have difficulty with things that they can't see. What they can't see sometimes doesn't exist to them, and it's not really related to who you are or what they think of you, so much as how they see the world and how people relate to things that they can't see. But we can misinterpret that as meaning that they see you that way rather than something that they actually can't see that's invisible to them. So communicating pain is really an important factor here. Worrying about what to tell others is something that you can focus on. It's not helpful though. Believing that you must tell others everything, and if you do tell them everything, they will understand. That's not necessarily true, as some of you may have experienced. You can make others understand. That's not necessarily possible as well. Sometimes people, again, what they can't see, they don't necessarily understand, and all of the information in the world isn't going to change that for some people. You may feel judged regardless of what you say, and finding a balance between communicating what's helpful information for you to communicate to them, without overwhelming them with all of the details, the medical details, and also maintaining your own privacy regarding your medical condition. So communicating what you need to. I need to do this, I need to take a rest, and then I'll be back, I'll join you guys. That's mostly really what you need to tell a lot of people, rather than going into detail regarding your symptoms and how you normally deal with them and what's actually happening in that situation. But what you need to tell them in that moment, in terms of how you can manage your symptoms, is the most important thing for you. And the pandemic, I believe, has encouraged a lot more flexibility in thinking and problem-solving approaches. So people have now had a lot more time to be modifying activities based on the pandemic. And so when you have to modify something, they will have experienced modification themselves in terms of work, in terms of social activity. It changed a lot of things for at least 3 years for people. And so there will be more understanding, I believe, as a result of that, at least for most people. So another term that's often talked about is acceptance. Have you accepted your condition? And so what is acceptance? It's not resigning yourself to the pain, the illness, or the suffering. It's not taking on the role of a patient or disabled person. It's not giving up necessarily unpleasurable activities or interests. What acceptance is being able to acknowledge the reality of a situation. It's quitting the efforts that are not working for you. It's selecting workable strategies, things that are actually meaningful goals for you, redeveloping what your purpose is. We all need to feel we have a purpose, and you are really the only one who can create that. And acceptance is moment-to-moment choices. It, each moment, each day, there may be changes. And again, it's being able to modify and go with what you need to at that time. Also, in terms of aiming for acceptance, you are looking at adopting a realistic perspective of life with lupus and where your symptoms are at in that moment, in that week, in that particular event. Related functional changes also that may have occurred. So you're basically looking at aligning your thoughts and your emotions with your body and how your body is behaving. You're looking at your functional abilities as they're not an all or none proposition. If I can't do it all the way I used to, I can't do anything. That's not a useful way of looking at how to function. Again, it's looking at what control do you have. And you might look at control in terms of influence rather than 100% control. So what influence do you have over your symptoms? How can you influence them versus controlling them? So you aren't going to be able to wipe out your lupus, but you do have influence over it in many different ways. And if you really think about how you've influenced it, what triggers it, perhaps stress, anxiety, poor sleep, things like that can worsen your symptoms. And so how can you influence those things? The picture I have here on the right is a picture of my dog Dexter, the large black dog, with his little buddy Ruthie. When he met Ruthie when he was 10 to 12 weeks old, and they were about the same size. And within literally a matter of weeks or months, he was much, much bigger than her. She's 8 pounds and he is 92 pounds. So they have learned how to adapt to their differences in size as he's grown, and learned how to be able to be around each other without him crushing her or harming her and still have fun. So it's just, again, this is a fun example of adapting to things and modifying activities so that you can still enjoy your friends and in ways that are possible for both of you. So looking at addressing the emotional and psychological impact of your conditions, medical conditions, stress and worry is going to play a role potentially. Depression is very common in situations, feeling irritable because, again, you may have been changed the way that you do things or what you can or can't do. You may feel helpless or hopeless at times because there doesn't appear to be an immediate solution. You may have a fear of flare-ups, and it may be at certain times or any time. Will I flare up before I have to go to the family wedding or to a dinner or whatever? Relationship issues may occur, again, because the relationship might shift depending on how your functioning has changed. Relationships with everybody, with friends, with family, with children. So relationships may shift as well. And there may be a factor of loneliness because sometimes people, when they're not able to do the things the way they used to and you're not feeling like yourself, some people will socially withdraw. And again, that's really not helpful for your mood. It's not helpful for your stress because it does increase both of those things. And it can really have a detrimental effect on your emotional health. So the management plan, we need to focus on that. So start listening to your body. You won't eliminate the symptoms, but you can learn to reset the alarm level and how you respond to the alarm. What do you do? Do you read the signals and interpret it appropriately? Or do you hit the panic button, the catastrophizing perceptions? That's not helpful. So learning symptom management strategies is very important from a physical perspective, from an emotional perspective, from a cognitive, and from a behavioral perspective. And so cognitive behavior therapy has been researched very extensively and found to be the most effective psychological approach to treating people with chronic pain and chronic illnesses. It looks at the automatic thoughts that are created that create an impression of illness that negatively impacts your coping. How are you coping with your condition? And CBT focuses on the cognitive processes underlying the illness beliefs, and we all do have beliefs about what is illness. How are we ill? How do we behave when we're ill? Behaviors that need to be stopped or modified, so things that aren't helping, and then looking at coping behaviors that need to be reinforced, that we need to strengthen and support. So basically, in terms of cognitive behavior therapy, what you think and do does affect the way that you feel. So an example of that in terms of the cognitions is restructuring your thoughts. So an automatic thought you may have would be, my symptoms are totally out of control. And of course, with that, you would feel helpless and you may become depressed. You may feel irritable. However, you can look at your thoughts, recheck those thoughts, and think about it from a very different perspective. I can do things differently to help my symptoms. So if you have that thought, replacing my symptoms are totally out of control, that will lead to a different emotional response as well. So if I can do things differently to help my symptoms, I might have some hope and I might move forward and try another strategy. So again, our thoughts are really going to drive our behavior. The second one, I'm tired after 1 hour, so I can't meet friends for dinner. Again, I can arrive later, allowing myself to manage my energy level. And so again, very different beliefs. With the first initial belief, you may decide you're not actually going to go. With the second belief, you have a plan and you're probably going to attend and hopefully enjoy the dinner with your friends, but you have found a way to adapt. And then the third example, one good sleep doesn't mean I will have others. So, if you had a good sleep, it's like, wow, I feel refreshed, but that's probably the last one. I'm probably not going to have another good sleep. Again, leaving you feeling down and depressed for the day. Whereas looking at it from another perspective, one good sleep means I am capable of good sleep. And that's a fact, actually. If you have had a good sleep, that means your body is capable of more good sleep. So you would then want to think about, well, what are the factors that might have been involved in that good sleep? What did I do the night before? Was I feeling more relaxed? Was I less stressed? Did I have a meal earlier in the day rather than before bedtime? Did I have some activity? How was I feeling? And were those things contributing to better sleep? So that would lead you to looking at what were the positive factors and how can I try to reproduce that? And so in terms of symptom management, you want to look at what are the things that are not helping, the don'ts versus the do's. So don't accept disability, challenge your beliefs. Don't avoid activity, but pace your activities. Don't stick to the old ways. Try to change up your routines to see what's actually working. Relying on medications solely, there is a role for them, but not the only role. So there are other things you can do, like exercise and doing relaxation techniques. Catastrophizing, again, is not a helpful perspective, but you might want to shift that to a problem-solving perspective. And staying in the past, obviously, is going to keep you stuck in that comparison mode, I used to do this and I used to be able to do that, versus setting new goals. That's a much more helpful way that will actually move you forward. And then isolating yourself is another thing that you don't really want to do because it isn't going to be helpful. Finding ways to socialize and reconnect is going to help your mood and your behavior. So the other thing about approaching your condition or approaching any chronic condition, the biopsychosocial model of pain and disability is the most widely accepted and helpful perspective. It's sort of a holistic or heuristic treatment approach. And it's basically looking at interdisciplinary care, so coordinating services with a common philosophy of rehab and communication among healthcare professionals. So I know that in this day, it may be difficult because people are working in different locations. And even if you have all of your healthcare providers under the same roof, they also may not be coordinating their services. They may have different philosophies, and you might be left confused as to one person told you to do this and another person told you to do that, and they might be opposing views on what to do. So asking your healthcare providers to communicate with each other so that they can come up with a common approach for you, and not leaving you confused and the one to make decisions. So you can ask your healthcare professionals to speak to each other, because that would be the most helpful approach. And you can be involved in those meetings with them. So perhaps if you're physio or your occupational therapist or your GP, and if you have a pain specialist and a psychologist, to talk to each other. And again, ask if you can be involved in some of those meetings so that you are all on the same page and you're all setting goals that are helpful for you and meaningful. So just on to just have a few brief slides on emerging treatments, and I wanted to cover those so that you have a little bit of background information on them. But this is sort of a fun little slide to start that off. In this slide, there's a dog on a couch with his therapist there, and he said, "I have a confession to make. I don't come here to be psychoanalyzed. I come here because you let me on the couch." And so sometimes people use different treatments for various reasons. It's not always for what the therapist thinks is the therapeutic value, but if the patient is having some benefit from it, that might be all that matters in the moment. So what's trending? What is trending now? And you probably, most of you, if not all of you, have heard about the microdosing. It seems to be quite popular these days. Microdosing, technically speaking, the definition of that is it's a process in drug development and selection where a minute dose of a substance is used to access characteristics of a drug. That's basically what microdosing really is meant for. But it's sort of transitioned to psychedelic microdosing, where they use 5 to 10% of usual psychoactive drug. Psychoactive means that generally it's a hallucinogenic or can be a hallucinogenic type of drug. So you are not necessarily in touch with reality at the time that you are taking it. You're sort of in an altered state. And so the components of microdosing is use of a low dose below the perceptual threshold that does not impair your normal functioning. It includes multiple dosing sessions, and it's intended to improve well-being and enhance cognitive and or emotional processes. That is what's intended for the microdosing. So let's have a look at some of the research and what it has looked at. So microdosing, the substances that have generally been used, the ones most commonly used have been psilocybin, which is magic mushrooms, LSD, which we know is acid, ayahuasca, MDMA, which is ecstasy, and ketamine. So pretty much all of these medications or medication substances have a hallucinogenic component to them, except for the MDMA. It doesn't have that hallucinogenic component. So the time frame of the review of these of the research was from 1955 to 2022. So the number of peer-reviewed published articles was 44. There were well over 1,000 studies that were published, but only 44 of them were ones that were considered to have had a solid methodology and were reviewed by a peer-reviewed journal, which means that it had a higher standard of research, methodology, and analysis to it. And out of those 44 studies, only 4 of them were actually studies that were basically pre-planned in advance and had hypotheses set out and measuring outcomes. 17 of those studies actually were placebo-controlled, so they meant that they had a placebo control group. So a control group where they weren't receiving a substance, but they thought they were, which is one of the only ways to properly test whether a substance is working or whether it's a substance that you think is working. Most of the participants in these studies were what they considered microdosing enthusiasts, people who really were already on board with the microdosing, which isn't exactly the best way to study a substance. You really want a variety of people, a range of people, so that you're not, again, getting what they call a placebo effect. The time span for assessing these effects was only 6 weeks or less. So for the vast majority of these studies, it was a very short-term assessment of the effects. So let's look at the limitations of the microdosing research. There was a lack of documented research plan and analysis, which is needed. So what we need are more prospective studies where people are actually planning it in advance rather than it being retrospective surveys, which were the majority of the studies. It's very important to have planned studies with hypotheses and test them appropriately. Accurate measurement of substances and dosing was not identified in the vast majority of these studies. Very important. There was a lack of a dose response effect. So knowing what level of dose actually produced a particular response effect, that also was missing in the majority of these studies. There was a lack of controlled exposure to the drugs. So there were many of the subjects in these studies who were taking the substance between the doses that they were allowed to or were asked to take. So it wasn't controlled in terms of how much drug were they actually taking during these studies. Specific measurement of treatment effects was not, again, properly measured. They just talked about well-being, which is very difficult, if not impossible, to measure, versus looking at something like number of symptoms that they reported, severity of symptoms of, say, depression or anxiety, or, for example, cognitive functioning. Did they measure their cognitive functioning in terms of memory tasks and processing of information? That also was not the type of functioning that was done. It was more generic, very ill-defined types of measurements, like did you feel better afterwards, that sort of thing. Again, it was either unclear or it was a biased subject selection in terms of what sorts of subjects were participating in these studies. And again, most of them were microdosing volunteers. And in terms of the follow-up, again, 6 weeks is a very short period of time. No drug would make it on the market if it was that short of a period of time. So there were many major limitations so far. So the microdosing research really has a long ways to go yet. So just in a quick summary, chronic illness is complex and can have significant impact on emotional and physical health, behavior, and relationships. There are proven psychological strategies to help the chronic pain and chronic illness sufferer. Continued investigation is needed to assess the safety and efficacy before such treatments as microdosing can be used safely outside of a research setting. At this point, they're really meant to be only in research settings. And patients typically benefit most when, of course, their healthcare providers have a shared philosophy and collaborate. They're on the same page. They're on the same page with each other and on the same page with you. So that's basically it. I have a final slide here with some self-management websites that you might want to access in a variety of areas. And I will be involved in the Q&A, so I will hopefully answer any questions that you have at that point. So thank you for participating.